Thank you very much for the introduction and for the opportunity to present here. I feel like I've got a little bit of an ungrateful task here because this is the DCB session. I'm sure you're not here because you want to hear about stents, but even in this era of the drug-coated balloon revolution, I think you should still care about drug-eluting stents, because the vast majority of our procedures we still do with drug-eluting stents. And even in the solutions trial, 20% of the patients who were randomized to the DCB strategy ultimately ended up with a drug-eluting stent. So I think we need to understand a few things about drug-eluting stents, because if you want to implant something, you want to implant something that will have the most optimal result for your patient. So that's why we'll quickly touch on the basics of drug-eluting stent engineering, the rationale of using polymers in drug-eluting stents, but also maybe why you would like to avoid those, some potential benefits of a thin strut polymer-free drug-eluting stent, and a little word about the stent selection in contemporary PCI in my own practice in Amsterdam. So you're probably well aware of the components of drug-eluting stents. There's a stent platform, it's metallic, it's either stainless steel or it's a chromium-based alloy. The chromium-based alloys usually allow for smaller strut thickness. Then there's a coating with a drug. It can be paclitaxel or sirolimus analogs. Paclitaxel has gotten out of fashion, so it's basically just sirolimus right now. And then there's some way to elute the drug over a prolonged period of time, and that traditionally was a polymer. But why would we maybe want to avoid using a polymer? Well, there were some significant issues with the first generation non-biocompatible polymers on the Cypher and Texas stents. And this is a scanning electron microscope picture of a Cypher stent that they tried to implant in a patient through a previously placed stent. They weren't able to get it past the stent, then they took it out and they put it under a microscope, and this is what you see. Lots of irregularities in the polymer. This can lead to delayed tissue coverage of the stent struts, which can then lead to a prothrombotic environment, and which can lead to stent thrombosis. And that's indeed what we saw with these first-generation drug-eluting stents, that there is a significant increase in stent thrombosis, particularly very late stent thrombosis, compared to bare metal stents and compared to second-generation drug-eluting stents. So there are a couple of strategies that were then used to minimize the risks of the polymer. And those include the using of increased biocompatibility. The first generation drug-eluting stents used polymers that were not biocompatible, but second generation drug-eluting stents used fluoropolymers. And the fluoropolymer is something like a non-stick coating on your pan. It hardly interacts with any other molecules, and it doesn't cause for any allergic reactions as the first generation polymers may do. Now, another approach may be to use a bioresorbable polymer. So the polymer is on the stent, but it gets resorbed slowly together with the drug, and then after a couple of months, you basically leave behind just a bare metal stent. And another strategy was to only coat the stent on the abluminal side with the polymer and the drug. And that way you avoid contact between the polymer and the blood vessel, while still having contact between the drug-eluting stent and the vessel where the drug can be eluted. The final strategy is avoiding a polymer altogether. However, that has a few engineering challenges, as we will discuss right now. Because when we look at the mechanisms of in-stent restenosis, we know that the inflammatory reaction to the barotrauma that we induce when we inflate a stent is the greatest during the first 2 to 3 weeks after stent implantation. This barotrauma leads to endothelial and vascular injury, which leads to fibroblast proliferation, and that leads then to neointimal hyperplasia. So the drug activity during this early phase after stent implantation is of the utmost importance. You'd need the drug to be effective for a couple of weeks in order to have adequate suppression of this restenosis phenomenon. Now, what happens if a polymer-free drug-eluting stent does not have these favorable drug release kinetics? Well, this was seen in the SORT 9 trial, where the polymer-free BioFreedom stent was compared against the Orsiro drug-eluting stent in an all-comer population. These were more than 3,000 patients. It was supposed to be a non-inferiority trial. However, non-inferiority was not met for these patients. And that was mostly because of an increase in target lesion vascularization with the uncoated polymer-free BioFreedom stent, which had TLR rates which were almost 3 times as high as the Orsiro stent. So how is it possible to still achieve optimal drug release kinetics while avoiding a polymer altogether? Now, there are several options to do this, and several manufacturers have applied these options. For example, a microreservoir and coating the sirolimus with a more lipophilic drug, for example, fatty acids, as was done with the Create stent. Or in the Vivo ISAR stent, they also use a microporous coating, but also coating with a Probocol co-drug in a shellac resin matrix, which can help to get these optimal release kinetics. So when we think about optimizing drug-eluting stent design, we want to use the best drug. We already know that there's sirolimus, which is favored over paclitaxel. There's no debate over that. We want to minimize the strut thickness. We want to minimize polymer-associated risks while maintaining adequate drug release kinetics, and also optimize deliverability by minimizing the crossing profile. And this is something where the polymer-free drug-eluting stent may perhaps also help, because there's no coating with the polymer. So the stent itself actually becomes a little thinner, crossing profile may be a little lower, and it may be a little more deliverable as a result. For the clinical outcomes, there does not seem to be such a great difference in clinical outcomes with polymer-free versus permanent polymer drug-eluting stents. So that's not really why you should have to use these polymer-free stents, but maybe the deliverability can be better. Strut thickness is also definitely important. Also for outcomes, we know this from this meta-analysis of more than 10,000 patients, where a significant reduction in TLF was shown with ultra-thin strut stents. But ultra-thin is perhaps not always best, and we know that from the PRISM-4 trial. That was a study in CTO patients, and it failed to show non-inferiority of the ultra-thin strut or Zero versus the Xience stent, with significantly higher rates of binary restenosis, and also TLR rates that were numerically higher with Orsiro, 9.2% versus 4.0% after 1 year. This is a kind of incomplete overview of currently available drug-eluting stents. You can see there's many differences in the types of polymers, being biodegradable, permanent, or even absent polymers, the differences in strut thickness. One stent that I would like to point out as well is the Vivo ISAR stent, which is on a cobalt chromium platform. It's polymer-free. It has a strut thickness for the small vessel sizes of 68 microns, so it's a thin strut stent, and a large vessel size of 79 microns. A microporous surface and coated only on the abluminal side with a sirolimus Probocol matrix in a shellac resin. This allows for fast endothelialization because there's nothing on the vascular side of this stent, the luminal side, but it still has release kinetics that are comparable to durable polymer drug-eluting stents. And one of the reasons why this stent stands out is because it's one of the few drug-eluting stents that has 10-year clinical experience. This is from the 3,000 patient ISAR Test 5 trial. This was run by Dr. Castrides' group in Munich. And you can see here in this landmark analysis that at the first year, also between 1 and 5 years, and between 5 and 10 years, there were no differences in clinical outcomes between the Vivo ISAR stent compared with the Resolute Onyx drug-eluting stent. And there's ongoing research as well with Vivo ISAR. The SECURE registry is currently ongoing. We are also participating in this study in Amsterdam. It's a single-arm study investigating the safety and efficacy of the Vivo ISAR stent with 3-month dual antiplatelet therapy. Up to 2,000 patients will be enrolled, and currently we are well over 60% of enrollment in the study and hope to complete it by July of this year. So to summarize, for stent selection in contemporary PCI, sirolimus and its analogs are preferred over paclitaxel. Cobalt chromium or platinum chromium is preferred over stainless steel. But for most lesions, ultra-thin struts are preferred. However, there are certain subsets like aorta-ostial lesions, CTO lesions, maybe heavily calcified lesions, where you may prefer a little bit more radial strength and where some thicker struts may be required. The polymer does not seem to matter that much. It has to be biocompatible, biodegradable, or polymer-free. They all seem to be very acceptable, provided that they provide adequate drug release kinetics. However, a potential benefit of the polymer-free stents can be increased deliverability because of lower crossing profile due to the lack of polymer, particularly when used in a thin stent strut platform. And finally, our experience with Amsterdam UMC, we basically use two types of stents. We have an ultra-thin drug-eluting stent as the standard for most lesions, and we use a thick strut DES with increased radial strength for ostial or heavily calcified lesions. Thank you very much.